It's my honor to be here with 5 advocates from 5 countries around the world, and they're going to be sharing a bit about life with diabetes in their country and the advocacy they're carrying out on the ground. It's going to be really exciting to hear about this and to hear about what's going on in their country. I'll introduce each speaker before they share. We're going to kick it off with Sana Ajmal from Pakistan, who's doing some amazing work there. So please take it away, Sana, and then I'll introduce the next speaker after you've shared your updates.
Thank you so much, Les, for inviting me to present here today. Hello, everyone. My name is Sana. I'm from Pakistan. I've been living with type 1 diabetes since 1998. After my interaction with the young leaders from the world over at IDF in 2011 and later on at many other forums, I realized how big and complicated the problem of access to good care was. And it wasn't just the people in developing countries facing it, but even those living in developed high-income countries were at risk. So over these years, I've known numerous stories where people have lost their lives because they couldn't access good care, and it just saddens me deeply. So Meethi Zindagi, of which I'm the founder and executive director, was founded around the same time as Type 1 International, and the advocacy efforts of Type 1 International propelled us actually to initiate an on-ground support program for children with diabetes in Pakistan. I cannot appreciate Type 1 International enough for what the organization is doing for the cause worldwide. We realized that while we advocate for change, we could just not leave these vulnerable children unsupported. So I'm very proud to say that we're the first people's organization, when you may call it the patients organization. We're the first people's organization in Pakistan who have taken up insulin support for deserving children as a nationwide initiative. And as I go through my talk, it will be apparent how the model addresses many of the access problems simultaneously, and how Type 1 International has actually helped us develop this model through its advocacy. So I'm going to tell you a few stories. And before I begin, I want to disclose that we have public media sharing consent for all of these stories. And I have no conflict of interest to declare. So here, if you see this first picture, this is of Laiba. Laiba is 12 years old, and she has been living with type 1 diabetes since 2017. Can we go to the next slide, Liz? I would like to start with Daim. So Daim, if you see here, Daim, his father is a security guard with a monthly income of $100 per month. Daim was too young to be able to manage on premixed insulins, which requires a lot of regularity in lifestyle, and he's only 18 months old. The government support provided to everyone in Pakistan is generally premixed 70-30, and there are very few hospitals who will offer free mixing regular in NPH. Analogs are too expensive to afford, and it was difficult to manage with human insulins for this child too, though they are cheaper, but he just could not manage on those. He was too young. Not to talk about the blood sugar checking needs that the blood sugar checking strips that needs to be done, and all those needles and accessories one needs. So distressed, Daim's mom reached out to us. He's receiving support from Meethi Zindagi since 2018. The government definitely needs to incorporate better coverage, and also all the other support organizations really need to incorporate better coverage. What we are doing for him is that the insulin that he needs is provided to him as per his requirements. Can we go to the next slide? So the second issue that we realized was very commonplace was the long waiting lines. Meet Neha. Her father is a laborer, which means that he, at his best, can get $6 a day for a day's work. There's no work half of the days. His mother works as a support staff at a school, and the family earns a total of $200 each month to feed a family of 6 members, out of which Neha also has type 1 diabetes. So government support, although available for the kind of insulin Neha uses, was difficult to access. The waiting times at a government hospital to get that free insulin can be exorbitant, and it may mean loss of work. Many a times, they also find that it was not always at regular intervals that insulin would be available at the hospital, which simply meant that they would have to return for it the next day, and further loss of work. Now, diabetes is not a temporary condition where you can just go through the trouble for some time and hope for a cure and better conditions later. So again, looking for options, their doctor directed them to us, and she has been receiving support from Meethi Zindagi as well. at her home. So we deliver her insulin to her home so that her parents do not have to miss work days. She does not have to miss schools, and regularity is ensured. Next, please. So meet Khadija. Many times there are such long travel distances involved that people actually find so much trouble accessing the basic care that they need. Khadija was born with many complications, including a dysfunctional pancreas. She lived with her mother in a mountaintop house, which was a 2 hours hike from the nearest medical dispensary. Her father worked in a city which was a travel distance of 6 hours from her home. This child needed 1 unit of basal insulin every day, 1 unit only. The government could not provide that, and the parents could not afford that. The child used to go severely low with all other insulins. So let's not even go to the checking requirements. The 1 unit insulin, which hardly went 1 pen every month. Her father needed to take that 1 insulin pen and some tested boxes to the home on monthly visits. This little angel was registered with us for support for a short 2 months period, but passed away after an epileptic seizure at the age of 5 months. The mother could not get her to the dispensary on time for being taken care of. So she was a very sad story, but the travel distances involved sometimes are just unmanageable. And we really need to think about models where people can actually be supported where they are. Next, please. So meet Adil. Adil was diagnosed with type 1 diabetes in 2005. And once diagnosed, he was told by the school admin that he cannot come to school due to his condition. Parents were not eager to send him either. They were both completely uneducated themselves too. So once we started supporting him with insulin, it was just not important for us to ensure that his health is being looked after. We also wanted to ensure that he has a productive future, because education is always helpful in acquiring decent work. 22.8 million children in our country aged 5 to 16 are not attending school, according to UNICEF. Adil was encouraged to join school after being registered in the insulin support program, which is one of the prerequisites of being enrolled in our program, which he did. So this was also a very positive push in his life, not just towards his health, but also towards his future productivity. Next, please. So meet Hassan. Hassan left school because of financial issues his parents were facing while trying to afford his medical expenses. Hassan had developed complications early on due to his condition, and found us very late. He was supported for his medicinal expenses for a year before he passed away due to the complications. So finding the right platform at the right time, timely diagnosis, all of these things are again very much important when it comes to accessing the right kind of care. However, we lost him after a year. Hassan had joined back school because of his complications. He had left school early on. He was bullied at school due to his condition, but he joined back school after getting peer support and insulin from the organization. Next, please. So meet Abdullah. He's on our insulin support program too. This bright soul aspires to become the next Wasim Akram, and I hope many of you would know Wasim Akram. He's a cricketer from Pakistan who is a world record holder and had type 1 diabetes. We would be supporting him till he turns 18, or if he continues his education till the age of 21. His future can be as bright as his smile, only if his hand is held and someone actually helps him go through this difficult time in his life. So next, please. So these stories talk about 4 major issues. One is the affordability problem, the second, and the flexibility of treatment choices, the access to test strips and needles, and not just insulin. So it's not just to make them live, it's also to help them live a good life. The second is the long lines that one has to wait for for accessing free government support, causing loss of a day of work. The third is the availability of insulin at regular intervals may not be assured, which can result in rationing and further loss of work days. And the fourth is the question mark on the future. So thinking about all these 4 problems, we decided that when we support people with diabetes, because we just could not leave them alone, our Promise of Insulin program, can we go on the next slide? So once a child is registered with us, he or she may be from anywhere in Pakistan where a cold chain maintained courier service can reach. We support the child with all their medicinal needs till the time they reach the age of 18 years or 21 years in the case they pursue higher education. The support package, which includes insulin, test strips, and needles, is delivered to their doorstep at their regular monthly intervals. So they don't need to waste time and money on travel to wait in lines. And after due diligence by a committee, the child can be provided with analog insulins too. As a prerequisite, we require the child to join school so that there can be some assurance of a brighter future in order for them to be able to support themselves as adults. Now, this is the model that has worked really well for children in Pakistan. One of our supported children has just graduated as an engineer, and others are being able to focus more on their health and education now. Next, please. And on this, you can get it from the nearest pharmacy. T1 International really helped us to train our advocates, develop our key messages, and learn from case studies to develop effective support models and work on a step-by-step approach to make this a reality in Pakistan. Next. So I just strongly believe that building a solution for the advocacy puzzle is always possible when you look at the right ways and actually try solving problems one by one. So again, thank you so much.
Thank you so much, Sana. But it's really, really important to hear about the various struggles and challenges, as well as, it's wonderful that you're able to provide direct support and to focus on advocacy as well. And we're really, really grateful for all the work that you're doing and thankful for that. So thank you. Thank you again, Sana. I'm going to quickly transition to Serene Farhad in Lebanon. Lebanon has obviously gone through some difficulties, particularly recently, and Serene's doing some wonderful advocacy there. So I'll hand it over to you now.
Hi, everyone. It's first it's a pleasure to be here and be on board this amazing workshop. And I have to first say that Lebanon has been going through really tough situations, but I believe that through advocacy, through community, we are able to help as many people as possible. I have personally been living with type 1 diabetes for the past 13 years, and I have kind of wished to work with community because I personally thought that the more we educate people on their rights, the more we empower. So this is where the story begins. Can I have the next slide, please? So basically, I have to start with the fact that Lebanon has had over the past 2 years problems with lack of access to insulin, and before that we had kind of a lack of diabetes awareness, a lack of awareness to people's rights, to their the right of access to their medication. So basically that's when I crossed paths with T1 International, and I saw the kind of advocacy they were providing, and I thought we need that. How can we do that here? And I reached out personally to Elizabeth. I was like, how can we do that here? I want to help people here. That's how Positive on Glucose started. It was something I really wanted people to be positive on their glucose. I wanted to give kind of mental health support, and I wanted people to feel like there is a community of diabetics supporting diabetics, and together we can fight for our rights and get what is naturally ours. So basically the result was a growing patient-led community of people in Lebanon and the region. I've met so many amazing diabetics in the region too. So that has been basically the most amazing thing that came out of going with T1 International. Of course, I personally received the advocacy training, and that empowered me to know exactly where to start, how to kind of decide on the goals. Like we figured out that we needed first to raise awareness, that people needed to know that, hey, wait, we have rights. And there we can start. And I think it was the perfect time to start because fast forward to now, we are among a crisis. And I think if that community hadn't been built then, we would not be able now to respond to everything that has been happening in Lebanon. Next slide, please. So basically, there is a kind of alarming situation for people living with diabetes, me included. I personally feel the pressure of having diabetes in Lebanon right now with everything going on. as some of you know, we had a revolution in October 2019, and it kind of ignited the collapse of our economy. We have a hyperinflation, we have a devaluation of the currency, and kind of the government has been, we don't have a government to begin with, it's absent. So basically, it's a really awful situation. People don't have access to their money, hence people don't have access to buying their basic medication and their insulin needs. Plus, there are things that have been running out of the market over the past period. So this all of it together urged us to kind of act. It's like a small patient-led group with minimal resources. I had to go back and forth with T1 International, kind of ask for advice, like what should we do, where should we start, because it was a very tricky situation. So here's what we've done. Next slide, please. So basically, because of it all started with also the COVID situation, the kind of problem escalated from there, and we started to raise our voice. We reached out to media outlets, we reached out to governmental figures, we started speaking about the problem. We were like, hey, listen, we have diabetes, we have type 1, insulin is air to us, like it's life support, it's not something we can choose to live without or substitute with something else. We started speaking about it and like making a big deal out of it, and to say the least, not a lot of people like that, but we had to speak up because that is our right, and we have to kind of live with the security that we have insulin. So that kind of worked, and then let's say the Beirut explosions happened. I think a lot of people heard about that. And part of the explosion that hit the port was kind of places where they stored medication. So that kind of also led to a bigger issue. Now we can't have access to our money to buy medication, and we don't have medication. So we had to improvise, we had to act quick. We realized that with 300,000 people displaced, with no refrigerators, with nothing, with no shelter, we had to kind of provide their insulin and their medication needs. And here we were not just looking at people with type 1, we were looking at people with diabetes in general, because everyone needed their medication. So again, here's what we did. Next slide, please. We kind of just made we joined efforts, Positive on Glucose, my platform joined efforts with 2 other platforms on social media, Noor and Nadine from 2 Instagram accounts, and we kind of said, okay, what should we do to make insulin and diabetes medication accessible? Here is where the community kind of all came together from all over, honestly, the world, all over the GCC region, the Arab region. People were just like, what do you need? We'll just send them over. What do you need? We'll just help you. And we kind of made this Instagram page where we told people what we were doing, and we asked people to reach out to us, and we were like, okay, we're gonna try to give you your medication. Next slide, please. We started teaming up with so many people who are part of the diabetes community, again, in the Arab region. We started talking about it on platforms, we started raising funds, we started gathering medication, and we basically were able to help so many people, but we had to kind of like verify the cases, make sure who needs what first, because so many people needed medication, but we needed to kind of reach out to the most vulnerable. So next slide, please. We started making sure like we had prescriptions to say what they need, how much they need per month. We tried to validate the information as much as we could. We did home visits. We tried to confirm that people are not like, you know, manipulating this issue to kind of resell or whatever, or be part of a bigger issue. And we were delivering medication home to home. Ever since the blast, we have been able to help around 100 people from all over Lebanon. You can see that in the next slides. We kind of showed the statistical data. People from all the ages, like I think the most fragile were those between 40 and 60, because these were people with type 2 who lost their homes, so we had to help them too. And if we can move also to the next slide, we can see that we covered all the regions in Lebanon, not sparing any, not just the one affected by the blast. I know it's like a small, like this big effort led to helping a small maybe amount of people, but this was solely through education. It was solely through community. It was the power of advocacy and community coming together to kind of help other people. So I really feel so proud of this. I really feel so grateful for T1 International, honestly, because if it hadn't been for them, none of this, I think, would have happened. So a really big thank you to all of you guys. And it just starts with being aware of what your rights are, and things go from there. So that's what we've been able to do over the past year and a half, and I hope we can do more together. Thank you so much, Elizabeth.
Thank you so much. Thank you. It's really wonderful to hear that despite the challenges, you've done so much, and I think that's a theme for this panel. There's so many challenges, but such amazing advocacy happening. So thank you for sharing and for the work that you're doing. We're going to quickly move to Pilar Gomez in Panama to share about the work that she's doing there. Take it away.
Thank you, Liz. Next slide. Thank you. My name is Pilar Gomez. I moved to Panama 3 years ago from the UK to find a very different country and a very different health system to support people with type 1 diabetes. My daughter has type 1, my brother and my mom, amongst other people in my family, have type 1 diabetes. And when we moved to Panama 3 years ago, I realized the time to give back had come, and I founded this charity called Diabetes Latam. Our main objective is to educate and support children and teenagers with type 1 and their families. Next, please. Panama is a relatively small country in Central America. It has 4 million inhabitants. Most of the population lives in the city, in Panama City. There's a total of 7 pediatric endocrinologists in the whole country, 6 of which work in hospitals in Panama City. Like many countries in Latin America, we have a 3-tier healthcare system. Very few people have private insurance, either paid by them or by their employer. And then the rest of the population is covered by the public system. 70% of the population is under the Social Security program for people who are either employed or self-contribute, mostly employed. And about 30% fall under the Ministry of Health. These are people that are either unemployed or work in informal economy and have very little coverage. We believe probably this percentage will shift after the pandemic because we're seeing a lot of unemployment, so that 70% will probably drop. What we have found, we're a very, very young NGO. We've been operational since January, having won a grant from the Lions Club in Panama and the Lions Club Foundation. So we don't have too much experience, but from what we have been researching, one of our main concerns is a lack of information. There's no medical census of a type 1 diabetes. There's a rough census for type 2, and then they just take a percentage of that and assume that there's about 400,000 people in total with type 2 diabetes, and then from a percentage, we're trying to guess how many children and adolescents have type 1, but we still don't have the number. When we try to investigate the public system and even the private system, we find that there's no standardized documented practices describing care and coverage under each of the 3-tier systems. So really patients are navigating in the blind, and even a lot of doctors either don't have full awareness of what's covered under the system that they work, or they're very shy reporting to us these numbers. So in the time that we have been operational, what we have found is there's inconsistent quality and availability of care in each of these 3 systems. Access to insulin supplies is not guaranteed, even with coverage. And so even people who are employed and contribute, they might find that there's availability of insulin one month and not the next. Navigating and using the system can be very cumbersome, very time consuming. And particularly with families that either don't have time or have a low educational level, this can be the difference between getting good care or not. And like in many countries in the world, the fear of losing a job translates into the fear of losing insurance and out-of-pocket costs that are probably impossible to cover. Next, please. With this in mind, what the Social Security program covers is they cover appointments, which can be either with a general practitioner all the way to a pediatric endocrinologist. It's really designed for those people living in Panama City. So if half of the population lives in the city, then the rest are probably abandoned by the system. Appointments are given in a scattered way, and there's, just like the example with Pakistan, there's a lot of queuing for HbA1c testing, collecting results, seeing a doctor, a nutritionist, a psychologist. So although the system is there, it's very difficult to access it without loss of time from work and from school for the children. Many children are on twice a day NPH and regular insulin, which on paper might work, but what we find scratching the surface and interviewing particularly teenagers is that it's a very limited approach to their lifestyle, and they experience a lot of burnout in the teenage years. Test strips and insulins are not always available, and sometimes even refrigerators are not available at home. The 30% of the population that falls under the Ministry of Health, these are uninsured patients, have no free insulin or testing kits, rely on donations, and will probably have to buy out of pocket. There might be some, in some cases, on some months, government subsidies, and other months they might need to buy it out of pocket. The minimum wage in Panama, the cost of living in Panama are very high. Minimum wage fluctuates between $600 and $650. Human insulin per vial, depending on where you go and if you get any subsidy, can vary from $3 to $40. Analogs are much more expensive, and pens and test strips are also very expensive. Next, please. Our realization is that we can't just sit back and look at all of this happening, and that a poor system exhausts individuals and even charities. And that's how we decided to create an advocacy committee, thanks to the help and training of T1 International. We set up a committee, we work very hard, we meet every week. We've received training and support, we've learned from others, and we have selected 6 initiatives. Next, please. We've been very ambitious on what we've selected. These are some of our members of our committee with the T1 International training materials. Next, please. And this is what we aim to. We want to participate in the implementation of 2 laws in Panama, which have been approved but haven't been implemented. And we fear that with the pandemic, these funds that were supposed to fund these 2 laws might go somewhere else. We're very firm believer in education. We want our children and adolescents to have access to analog insulins. We want to offer them the flash continuous glucose monitor, because we think that they can get much better control. We want them to have quarterly assessments with a pediatric endocrinologist, and monthly insulin adjustments and the meal plan review over the phone or over telemedicine. We know this is very ambitious, but we want to aim high, and we're willing to work as hard as we need to do to reach our goals. Thank you very much.
Thank you so much, Pilar. It's, wonderful work that's being done, and very much needed work as well. So thank you again for sharing. I'm going to again quickly transition to Ivan Okoth in Uganda, who's going to share about some of the, again, very important work happening there and the situation for people with diabetes in Uganda and Africa as a whole.
Thank you so much. My name is Ivan Okoth. I'm a program manager outreach with Sonia Better Foundation and a T1D warrior. Next, please. I was diagnosed at the age of 16, and at the time I felt my life at a dead end, and I've never amounted to anything in life. I spent a full 16 years without knowing what type 1 diabetes was actually. And for me, the last 10 years have been a time for me to have hope. And within that time, I've also been able to turn out to be a lawyer. I've made it as an SNF outreach manager, promotion program manager as well. Next, please. In Uganda, survival for a T1D is a function of 4 things: public health infrastructure, poverty, awareness, stigma, and psychosocial stresses, literacy, and T1D education. The healthcare infrastructure in Uganda. The next one. Next, please. We have 4 pediatric endocrinologists in the whole country of about 20 million plus children. And and 47.1% of the population is actually under 15. In Uganda, you actually find that diagnosis takes about 3 weeks for somebody to be able to be found to be with T1D, and many actually die before this happens. We have about 31 clinics in the country, and these provide free insulin under the Changing Diabetes in Children, as well as free syringes provided by the foundation, Serene Foundation. However, there's no countrywide policy or strategy for type 1 diabetes. Poverty, there's a lot of food insecurity. In northern Uganda, we found that on average about a warrior spends about 3 nights without having a meal. The transportation is very, very high. Warriors take about 5.5 hours to get to the clinics, and most of this is actually on foot. Parents earn less than $1 a day, and we find that 95% of the children actually don't have a refrigerator or electricity to store their insulin. Awareness, stigma, psychosocial stresses. At one of our camps in Western Uganda, we found that 28% of the children have been ousted out of school by their management because they feared type 1 diabetes. And 76% of them actually feel sad or anxious about this condition. 56% of them reported that they were facing isolation in their schools because people feared that they were contagious or they were cursed. Literacy and T1D is a very important aspect. We find that in northern Uganda, 98% of the children actually do not understand how to do glucometer readings and have an issue complying with their T1D regimens. Equally, 81% of them need help from their caregiver to be able to understand and manage the T1D themselves. So numeracy, literacy, cognitive skills are actually a very, very big important issue for us to achieve good outcomes. The future I would like to see, I'd like to see a future where there's access to insulin, syringes, essential supplies, because for us warriors, insulin is life. And sustainability of these essential supplies is a source of worry, continuous source of worry for the caregivers, the warriors. And so there's a need to bridge the gap of delivering these essential supplies to the warriors. And that's why the government and the NGO, the broader NGO community, will be very important. I would like to see, maybe if you could come down, next slides. The next one, please. Yes, thank you. I would love to see an improved health infrastructure. The health workers are not as knowledgeable as they should be about type 1 diabetes. So there's a need to train them so that they can be able to pass on correct information about the condition to the warriors. And education is a very, very big component of what we do. Programs like the SNF Border Project were brought in as a COVID-19 crisis response intervention, but these need to be scaled up to bridge access issues faced outside this crisis context. Next, please. Advocacy, awareness, and outreach. The best advocate, we believe, is a person living with a condition. So building an army of warrior advocates is very transformative. So we focus on training of advocates to improve policy environments, raise awareness, which we feel is important. So pictured here are some of the advocates in the Pamoja Advocacy Program that I manage, and which is a joint initiative between the Serene Foundation and Type 1 International. There is a need, next please, there's a need to focus on social determinants of health. Poverty is endemic, and it increases the challenges with T1D, because how can you inject when you don't have food? How can you find transport to clinic? This only leads to stress. Optimal T1D outcome and requires carb counting and adjustable insulin. But how can you do that when you can't trigger or count? Stigma in communities puts warriors at risk. Schools discriminate against warriors. This only leads to stress. Next, please. For us, community is everything. Without the T1D community, personally, that would be nothing. It's even harder in the developing world that we live in. So you need community support from communities that understand the condition. As the SNF outreach manager, my goal is to create a community that supports each other because we are stronger together. Behind me is a mural that is that has paintings upon paintings of warriors. If you go to the next slide, please. Behind me, this mural represents the community that we have at every camp, because we believe that together we can. Thank you.
Thank you so much, Ivan. It's really, really great to hear about all that work, and we're glad to be able to work in partnership, especially for Pomoja, and the work SNF doing is really, really important. Again, moving swiftly along to our final panelist, Kevin Wren is our chapter leader in Washington in the USA, and he's gonna talk about the USA as a whole and some of the things that are going on there. Thanks, Kevin.
Thank you, Liz. Here's a picture of my dog Georgie and I hanging out in a Insulin for All shirt. I've had type 1 diabetes for almost 20 years. My grandma was diagnosed when she was 19. My father and brother both have it as well. I think we're all aware insulin prices are the highest they've ever been in history, with a quarter of us rationing. What's less obvious is the extent Black, Indigenous, and people of color face when accessing health in the US. Aside from the social inequities like police violence and racial bias in our criminal justice system, these communities are facing high mortality rates compared to white people. The burden facing Americans living with diabetes are formidable, so we have to work together to mitigate biases, exploitation, and inequity. From the national effort by federal legislators trying to make insulin more affordable, to the individual testimony from Insulin for All advocates, the inertia to address the insulin price crisis is growing. Yet while we fight for our affordable insulin, manufacturers continue to extort unconscionable profits from us, and a third of our country is at risk of developing diabetes. Next slide, please. Here's a picture of our Connecticut chapter with Kristen Whitney Daniels, who is going to give a talk about divestment campaigns today. The US accounts for only 7% of the global diabetes population, but makes up 2/3 of Eli Lilly, Sanofi, and Novo Nordisk revenues on diabetes medications, with $1.9 billion earned by Indiana's Eli Lilly in the last quarter. Last year, executives from all these insulin manufacturers contributed tens of thousands of dollars to the same legislators aimed at maintaining the status quo. This is a clear conflict of interest. While these companies profiteer, they pay nothing in federal taxes. They continue their scheming and anti-competitive practices while desperately holding on to the patents for our medicine, preventing others from entering the market and providing competition. Next slide, please. There's Lena, the DC chapter social media lead. Focusing on the pandemic, the conversations around affordable insulin stalled at the national federal level. Before COVID, the Senate Health, Education, Labor, and Pensions Committee requested the 3 insulin manufacturers to explain the skyrocketing price of insulin. Additionally, the House Congressional Diabetes Caucus was getting ready to introduce and propose legislation in spring, but was sidelined due to the outbreak. Lately, the presidential nominees discuss insulin when talking about their healthcare reform plans, yet advocates have yet to be included in this conversation. We're used as talking points, which is why it is crucial we reach out and demand a seat at the table. Next slide, please. Here's Nicole, who's going to be speaking today at 10:10. The power of patient advocacy can be truly seen at the state level through the numerous insulin copay caps, as well as California's generic drug and insulin manufacturing bill. Please take a moment to go to California's Insulin for All Twitter and Instagram to like and share their post about SB 852. In Washington, we passed $100 copay caps, and through our direct testimony and advocacy, established a position on the state work group for a patient with diabetes to work on controlling the cost of insulin. The bill was passed 95 yeas to 1 nay. We are building on that momentum to introduce legislation like the current bill in California, allowing us to set a floor on the market for insulin and protect our supply and medical chains, while also creating jobs and revenues for the state. Next slide, please. There's Kylene, aka Black Diabetic Girl. Find her on Instagram and Twitter. She'll be speaking on Sunday. I think Dr. King said in Strength to Love really well. Please read that. Philanthropy is commendable, but it must not cause the philanthropist to overlook the circumstances of economic injustice which make philanthropy necessary. I think this explains the conflict of interest faced by the ADA and JDRF who take pharma money. Our state chapters have cultivated strong relationships with supporters and partners. In Washington, we found common cause for accessible insulin and medications with Healthcare for All Washington, the AARP, numerous hospital associations, pharmaceutical associations, nursing and healthcare unions, as well as those representing BIPOC communities. Too often these groups are not represented enough and the struggle is whitewashed. Yet, we make progress by sharing our stories, calling out the BS, and elevating each other's experiences. Next slide, please. Here's some of our Utah Insulin for All chapter members. As our voices are heard more and more, we will continue to make progress. We give context to the situation, detailing the struggle, encountering forces aimed at exploiting our illness. We need a seat at the table in order for us to be fully seen and to fully address these public failures. This coming election will determine much of the local, state, and national level, which will carry on over to 2021 and beyond. We are poised to make greater strides and build on the combined successes. We are making progress. In the words of the late, great Ruth Bader Ginsburg, real change, enduring change, happens one step at a time. Thank you.
Thank you so much, Kevin. It was great to see lots of chapters and various facts and looking forward incorporated there. Thank you so much. And thank you to all of our panelists. I think what's really clear through all of this is the challenges are many across the world. The challenges are big, but there's so much movement happening globally, and it just really shows the power of our global community, the power of taking action and taking one step at a time, even if it's a long battle. So this is really heartened me, and I hope to the viewers, hearing from everyone around the world. This is obviously a small sample of all of the advocates around the world who are doing this work, but we're just really grateful to all of you panelists for sharing. So, well, I think my question, which I think has come through some other questions that were answered individually, is if any of the panelists would like to chime in and share just a few words about what gives them the most hope looking forward. So I know you've all touched on some of this and you have very specific advocacy goals, but if you can just share a few words about what you feel most hopeful about when it comes to your advocacy and the community. Is it okay if we just go in order of the speakers? So if Sana has some reflections, and then we'll go down the line that way.
Thank you, Liz. I feel very hopeful because when I talk about this on-ground support program, what it has really stirred up is the interest of the community in this cause, because most of our donors, around, you can say 80%, is the diabetes community itself that are helping the other diabetes community. So when they hear the stories, when they hear about the cause, it really stirs up that passion in them to be able to advocate for it, with the policymakers and with the other healthcare organizations that can make an impact in the longer run. So that's the hope for us.
Definitely. Thank you, Sana. Serene, do you have some thoughts?
Well, yes. For me, at least here in Lebanon, because we had different objectives, just the fact that more people are coming out and talking about their diabetes is a milestone, because people here used to hide their diabetes and were not very open on talking about it to begin with. So like seeing people reach out saying, hi, I'm diabetic, I'd love to talk to other diabetics, I want to reach out, that for me is like a first step into creating the kind of community that pushes for change. We need more of that. We need more of, it was so hard to find diabetics, in Lebanon, even over social media, because they don't just show it. So things like that, just pushing the community into coming out of that box, sharing their diabetes, sharing their struggles, to know where we should start supporting them, and how we can come all together as a community to kind of push for change. So that's the case of Lebanon.
Yes, thank you so much. Wonderful. Pilar.
I think what gives me the most hope is to realize that when we work in advocacy, we're influencing the system, not necessarily an individual. And when you manage to make even the slightest change to a system, you impact everybody under the system. So it might be a very long-term goal. It might be painful. I think it's not a popular role to play when you work in advocacy, because it's very easy to step on the toes of the medical community, of the industry, of government officials, especially in countries where there's a lot of corruption. But I see absolutely no option, because if I can make one little tweak to the system in the next 1, 2, or 5 years, I know that once that becomes policy or that becomes a law, it's going to help everybody in the community forever.
Such an important point, and I think that's why it might take a little bit longer, but why it's so crucial. Thank you. Ivan.
Yes, thank you. What gives me the biggest hope is that the community has started providing examples from within themselves. The warriors are providing examples to other warriors with their good management, with their ability to overcome the adversities of life. And for me, that is the one thing that is giving me hope, because they are rising up, they are making the noise, they are being heard, and it's counting.
Yes, thank you. That's, yeah, couldn't have said it better. Kevin, any final thoughts on what gives you hope?
Yeah, I'd just like to echo what Serene and Ivan said about harnessing the network, like just meeting other people in our country and then around the world that are struggling with this is really inspiring to know that they're on the ground working. And then kind of what Pilar said too is just making that incremental progress and injecting yourself in and actually making a difference and seeing that come through and seeing other advocates do the same thing. That's what gives me strength.
Yeah. Again, we're all connected through this this hope. There are struggles, but again, seeing each other and kind of supporting each other through all of this and the community. The name of the workshop, got to get that in there, change the community. But truly, yeah, seeing and knowing the work that's happening, and that it is possible to find hope in very, very dark times, is I think what we all need. I know it's what I need. So again, thank you all for being here and for being a part of this. We're so glad to and you know, we'll keep talking and we'll keep advocating together. I know that's for sure. And I'll close it there because I want to leave it on that beautiful, hopeful note. And just to say thank you one last time.